शर्म नहीं आती आप लोगों को? आप सबको बस सेल्फीज और वीडियोस की पड़ी है। वो अंकल स्कूटर।
Guys, I have a request to please ensure that you all are mute all the time. Great. We, in our clinical practice, can have 14 lead ECG. Now, 12 lead we all have heard about. There are limb leads, there are chest leads. So there are 6 limb leads and there are 8 chest leads in circumstances of dextrocardia. Use V3R, V4R. Otherwise, there are 6 chest leads and 6 limb leads. So limb leads are marked as 1, 2, and 3. So to keep it simple for you, if you are standing at lead 1, then lead 2 will be at your left and lead 3 will be at your right when you're facing towards east side. But when you're standing upright, then AVL, AVR, and AVF. These are marked with the involvement of which limb you are using to capture the flow of electricity, and the tangents drawn and the vectors drawn are going to tell you about the direction, and these vectors help you in assessment of certain parameters. Similar parameters are noticed and evaluated on chest leads. Go ahead. We have important parameters which like P, P wave, QRS, T wave, U wave, intervals. All these are important to be calculated, but there are specific leads which tell us about a definite area. So right side leads are primarily AVR, that is on right hand, V1, that is on second intercostal space right side, V3R, V4R if at all we are using for dyscardia for right. The left leads primarily is being told by lead 1, AVL that is left hand, and V6. Inferior leads is said by lead 2, lead 3, and AVF. Are not shown much. Is my screen visible? When we talk about the first step in managing ECGs, we go in a form of a structure. First and foremost important thing is speed. So whenever you're looking at any ECG, go and see the speed. Speed is marked at the bottom of the ECG page, and generally in a second, 25 is being taken. One small box is equivalent to zero point zero 0.04 per second, and one large box with having five small boxes equal to 0.2 second. Why is it important? Because most of the calculations done for intervals or for any kind of um, waveform, most important thing is calculation as per the boxes it has taken into consideration. Now, calibration. Calibration is how much volume is that height responsive to, how much is visible, is how much voltage is being represented by how much volume, by how much volt represents how much height. So under standard circumstances, it is 10 which is representing 1 millivolt. If you see at the bottom of the page, 25 per second and 10 millivolt, 10 per millivolt is the marking being set and is printed. If you see the mark on the page, which is represented by an arrow, you can see the calibration. The height of the mark tells you about how much is the distance from the isoelectric point for which you have to take consideration to consider in your calculations. Now, when you talk about any ECG, if the half standard calibration is you are looking at, then you can understand that if you make it 10 per millivolt, then how much it is going to affect the visualization. Usually, in normal circumstances, we do not take we do not take half calibration. But in those circumstances where your leads or your findings are going beyond the ECG paper, then you bring it down by decreasing the calibration. What is good for electronic interpretation and machines? They are good for rate, they're good for axis calculation, for intervals, for right ventricular hypertrophy. Their interpretation is okay for left ventricular hypertrophy, and it is very bad for ST changes, Q wave changes, rhythm, or corrected QT intervals. In this ECG, only thing which we want to highlight is that when you talk about intervals, don't consider them as right and correct. But when you talk about axis, when you talk about P wave durations, QRS duration, then yes, you can take it into consideration. Limb leads. What and why limb leads are important? So limb leads are very important, and they tell us about the rate, about axis, about normal sinus rhythm, about P waves, about PR interval, and about Q waves. We do not tell about blocks. We do not tell about RS R pattern on the limb leads. And do we have to consider all the limb leads or any specific? Let us see. So when we talk about heart rate, it is marked by 60,000 divided by RR interval in millisecond. Now, one small box is equivalent to 0.04 second, that is 40 milliseconds. Box method, other easier way out is when you divide 1500 divided by number of small boxes, you give you between the two complexes, this gives you a heart rate. When you divide 300 divided by number of large boxes, that gives you an about heart rate. When you want to check about axis, then in P wave axis, you need to take into consideration only two waveforms. First is lead 1 and second is AVF. So in these two leads, we need to understand that any ECG has two axes into consideration. First is P axis, second is QRS axis. What and why? The P axis is relevant to tell us how atrias are behaving, and QRS axis is important and reliable source to tell how ventricles are behaving. Morphology of these P or QRS waveform tells us about rhythm disturbances, or also in cases when post-surgical there is scarring, we get some rhythm disturbances or permanent electrical um, activity at the site of scar, and problems like that, which may be confounding factor in making a decision when you're looking at these. So when we talk about P wave axis, we need to look at in lead 1 and in lead AVF, where in between 0 to 90 is considered as normal high RA rhythm, and from 0 to minus 90 is low RA rhythm. Under all circumstances, normal, with example I'm going to show on the next pages, under normal circumstances, P wave normally is 0 to 90 and his high RA rhythm. By that, what I mean to understand, if you look at this ECG in lead 1 and in lead AVF, you can see a positive deflection before QRS complex. The positive deflection in lead 1 and in lead AVF tells you that the vector and the B waveform and the axis is in high RA area, which is considered as normal. In next slide, if in this we see for 6-year-old in lead 1, there is P wave deflection, and in lead AVF, the complex is suggesting of negative P wave deflection in AVF. This is suggestive of low RA rhythm, that is axis is abnormal. So looking at P wave tells us about how the electrical current is flowing in, whether there is associated problem or whether there is no associated problem involved. Now, when we come to QRS axis, we have to remember that QRS axis is divided again into 4 different quadrants. Lead 1 and lead AVF will tell us all about the factors involved, that is 0 to 90, 0 to plus 90. In lead 1 and lead AVF, we have normal axis, normal QRS axis. From if the QRS waveform is having negative deflection in AVF and positive deflection in lead 1, then we will have left QRS axis in upper quadrant. Then if we have negative deflection in lead 1 and positive deflection in AVF, then it is again in the abnormal area. Going ahead, one axis which we should remember is the lead AVF. If at all there is a negative deflection in AVF, then that means it is a left axis deviation. And when there is a left axis deviation, that means ECG is abnormal in pediatrics. So left axis deviation is denoted by either there is a negative AVF axis and negative QRS axis in AVF, or we have negative in lead 1 as well as negative in AVF. When we have negative flow of vectors in lead 1 and negative flow in AVF, then we also tell this as a northwest axis or superior axis. As a rule, left axis deviation is never normal. What are causes of left axis deviation? AV canal defect, partial or complete, tricuspid atresia, WPW syndrome, single ventricles, left anterior hemiblock. They are associated left ventricular hypertrophy. Going ahead with axis deviations in this ECG, when we start looking at the ECG, always remember your first step should not be jumping to axis. First step should be look at the rate at which speed the ECG has been taken. Look at the calibration at which ECG has been done. After this, go ahead and check for limb leads. In limb lead 1 and limb lead AVF, check for P wave. Both are in positive quadrant. That means it is PRA, normal rhythm, normal P axis. Then we go to QRS axis in lead 1 and in lead AVF. we can see that the positive deflection in lead 1 and there is net negative deflection in AVF. To calculate the deflections, we need to mark above and below the isoelectric point. The number of squares below isoelectric points are taken as negative and above are taken as positive. In this, you can see that around 3 to 4 squares are in positive and around 9 to 10 squares are in negative in AVF lead. So we comment this as left axis deviation. In when we talk about limb leads now, the other thing which we can get is normal sinus rhythm. Now the normal sinus rhythm is another aspect which we are going to understand only through limb leads, and we know don't need chest leads in this. Normal P wave axis is what we have received once we see positive deflection in 1 and AVF. What is normal sinus rhythm? It will have a normal P wave axis. There will be one P wave preceding every one QRS. P wave morphology will be always fixed. PR interval will be always fixed. In this child, if you see, normal sinus rhythm says that every P wave will have uniform morphology. Every P wave will precede a QRS. In lead 1 and in lead AVF, there will be positive deflection. So there will be sinus rhythm and there will be normal axis with fixed PR interval also. So 4 pointers will tell you that this is a normal sinus rhythm. If any one of them is missing, then definitely you need to check for conduction defects. Going by example, again, speed checked, calibration check, P axis checked, Q axis checked. If somebody asks about P axis in this case, so we have low RA rhythm in this case. We have P axis with lead number 1 showing positive deflection and arrow shows that in AVF there is a negative deflection. So it is not a normal sinus rhythm. It has a low RA rhythm. If we would be having a positive deflection in AVF, then it would be a high RA rhythm. That is a normal sinus rhythm. Rest other pointers to be checked to comment upon as a normal sinus rhythm or an abnormal sinus rhythm are whether there is preceding P wave before every QRS, whether there is associated normal PR interval, whether morphology of P wave is normal or not. When we talk in next session, we will talk more about etiologies and problems. In introduction, we are going to go step by step. Before going to next slide, let us see this X-ray. First and foremost thing is speed, calibration. Then comes lead 1, lead AVF. What in lead 1? P wave, deflection positive. Lead 2, P wave, deflection sometime positive, but sometime negative. Where and how? If you see complex number 1, in lead 1, it is a sure shot positive. Complex 2, maybe positive, maybe not. Then we come to AVF, complex 1, definitely negative. Complex 2, definitely positive. So what is happening? There is a different P wave axis. There is a different P wave morphology. Such kind of pacemakers are called as wandering pacemaker. These are marker of dyselectrolytemia with associated rhythm generation and spread of conduction in different direction, more prone for atrial flutter, more prone for other arrhythmias originating from atria. Coming to next portion from limb leads is calculation for P waves and PR interval, last calculation of Q waves. So when we talk about P wave morphology, we note it in lead 2. Now in lead 2, we have two waveforms which are important in P wave. That is P mitral, P pulmonale, which are abnormal. When we tell about a normal P wave, it should cover 2.5 into 2.5 boxes. That means the size, normal P wave on morphology should not be beyond 2.5 in length, not be beyond 2.5 in breadth. If it is tall, then it means it is P pulmonale. If it is broad, that means it is a P mitral. So whenever there is associated abnormal P wave morphology, we all understand that our consensus of telling it as rhythm, normal rhythm, will not be there. Let us go with an example. When we talk about P wave excess, we go to lead 1 and lead AVF. But when we talk about P wave morphology, primarily we look on lead 2 and not any other lead. So in lead 2, in this we can see that the waveform is length is although 2.5 small squares, but height is more than 2.5. So this is definitely P pulmonale. And relevant or not relevant, we are not going at this moment into considering that, because we have sessions lined up to go into what pathology we are dealing and what are the changes. Let's go. And before we jump to P pulmonale or P mitral, ground rule of uh, calibration and speed should always be addressed. In this child, again, we have lead 2 with morphology of P pulmonale with the speed of 25 per second with normal calibration. When we talk about P axis, then we have positive deflection in lead 1 and positive deflection in AVF. But when we talk about rhythm, no, we cannot say that it is a normal rhythm, because the dimensions and P mitral is visible, so it is not normal. Morphology, although is constant, but it should not be considered as normal sinus rhythm. PR interval, regardless of age, normal PR interval is 0.08 to 0.16. That is 2 to 4 small squares. When do we say prolonged PR interval? Anything beyond this. Where do we find it? In first degree heart block, PR interval prolongation is seen. It is a very common finding in atrial septal defects or in repaired tetralogy of fellow cases. When do we have short PR interval? When the transition of information between atria ventricles is rapid. That is WPW or Pompey's. When we talk about Q waves, which are very significant in adult population, in pediatric, they are telling about ventricular septum and not infarction. Only thing, only lead in which we look for normal waveform is lead 3. Q wave as per age should be seen in lead 3. It is normally also seen in inferior leads, that is AVR and V6. It can be 1 box wide and 5 boxes of height. And if at all you see that lead 1 and AVL are having Q waves, it is Al-Kappa, anomalous origin of left coronary artery from pulmonary artery. And if it is wider than 1 box, then probability of infarction associated is there. If you see they are deep enough with more than 5 boxes of height, then LVH, left ventricular hypertrophy, is what you're dealing with. Same case, lead 1 for excess height, we cannot tell about speed and calibration. Calibration, yes, we can, but high speed cannot. Then we talk about Q wave. So as I said, we take lead 3 to look for age. Normally in AVR and V6, we can get Q wave. We do not respond to them. But if we get a lead 1 and AVL with Q wave, then we consider them as abnormal and we have to find out the cause behind it. If you see in lead 3, we have Q wave, but the number of squares in the height are more than 5, which is significant of left ventricular hypertrophy. If you do not go towards the chest lead side, only with limb leads, you can tell about left ventricular hypertrophy by assessing Q wave morphology in lead 3 as per the age. If it is more than 5 squares, you can consider it as an left ventricular hypertrophy ECG. Now, again in this ECG, we can see that in AVL, we are looking at Q waves, which are we have to check the dimensions and we have to check how many height that Q waves are taking. And once we confirm that yes, Q wave is present in AVL, we can start looking for Al-Kappa. We can tell our cardiology colleagues to have a look at this patient for origin, abnormal origin. In this, Al-Kappa as a presentation is a serious etiology, and the child may lose his or her life if not diagnosed quickly. How do we say that this is a Q wave and not S wave? So positive deflection seen from the isoelectric line is usually seen after Q wave. There is a positive deflection of R, then ST elevation is there, then a P wave is there, and then a QRS complex again is forming. So when we talk about chest leads now, briefly, we are going to go ahead with chest leads. The important chest leads in the beginning, like I mentioned, we should consider V1 and V6 always. V2 to V5, we can ignore in pediatrics. These V1 to V6, V1 and V6 primarily tells us about morphology of T waves, which marks repolarization of heart, and morphology of uh, QRS complex, which tells us whether the height of R or S is significant, whether there is RS R dash pattern present and is significant of RBBB, right bundle branch block or left bundle branch block, and how do we calculate corrected QT interval. Relevance of ST segment also is marked on this wave, on these leads. So as a rule, in V1 and in V6, T waves are below 1 week, that is in neonates before 7 days. T waves shows a positive deflection in V1. They are always positive in V6, even till adolescent. So as a dictum, if you get a negative T wave in V6, it means it is abnormal. Negative T wave from 7 days onward till adolescent is normal. So if you get a positive T wave in lead V1 to V6, lead 1 and V6 from, let's say, from 1 week to adolescent, then consider it as an abnormal finding. Why and how? So the T wave morphology is the positive deflection after QRS and after QRS. In this ECG, we can see the positive deflection at R, positive deflection at Q, at T wave is marked with an arrow, and the second arrow is exactly above T wave, and first arrow is kind of arrow to delineate the ST segment with the proper S coming to isoelectric line and origination of T wave. So when you have T wave for in a 1 day old child, you can see positive deflection in V1 and a very subtle positive deflection in V6. Actually, the second arrow in V6 clearly shows the positive deflection, although arrow number 1 in V6 is not that descriptive. When we check in 3 months, there is a negative deflection of T wave in V1 and a positive deflection of T wave in V6. So in to keep things simpler, when we talk about limb leads, we are primarily focusing on lead 1 and in lead AVF to look for E axis, QRS axis. We look on lead 2 to tell us about P wave morphology. We look at lead 3 to tell us about Q wave. AVR and a lead 3, they give certain information about Q wave. When we talk about AVL, it is about Al Kappa and Q wave. When we come to limb leads, it tells mainly about the ventricular path. QRS axis, duration, T wave morphology, T wave presence of deflection, positive or negative, as per age, gives us about the changing morphology of heart, whether there is a evolving pressure on the heart, whether the child is having undiagnosed VSD, all these things. If you do a ECG with this type of pattern, if you get a positive deflection of T wave in lead one, then if it is abnormal, you are definitely going to go ahead with echo, and you will auscultate such cases more logically. Is going to help this aid. ECG as a aid will be useful to you if you remember these simpler points and try not to just give a ECG finding on looking at long lead 2. Coming to this ECG of 6 year, like we said, in V1, T wave morphology will be in negative part, and in V6, again, T wave morphology is in the positive zone. So we have a positive deflection. In adolescent, if you see the T wave morphology in adolescent, like we said, it was negative only till 7 days to adolescent. Again, as adolescence increases, the flow of the blood in that increases, and the positive deflection of T wave, maturity of conduction system improves, and we have a positive T wave in V1 and a positive deflection in V6. Now, what is abnormal? Let us see in V1, we can see that in a 3-week child, we have a positive deflection. And in V6, we have a positive deflection. So technically, this child who is having a kind of flat T wave in V1 is a case with right ventricular hypertrophy. If we have negative deflection in V1, in this case, again, we will see in V1 and V6, there are positive T waves in V1, which is suggestive of right ventricular hypertrophy in a 7-month-old child. Why it is important? Right ventricular hypertrophy means that there will be more chances of developing Eisenmenger, or there is associated pulmonary stenosis, or there is a more volume overload on the right side. So right ventricular hypertrophy needs further evaluation, and you have to understand that your auscultation gives you a bigger and a better clue in these cases. When you have a positive T wave for 7 days to adolescent, right ventricular hypertrophy should come to your mind. Strain on right ventricular should come to your mind. Now, when you talk about RS-R dash pattern, there are two RS-R dash pattern. One is V1. If you see it as a figure, it it is shown as RS-R dash. A M can be seen, and if you see it in V1, it is suggestive of right bundle branch block with right ventricular hypertrophy. When you see the QRS duration in V1, you can actually see that with what is the height of R wave. If the height of R wave is more than 10 mm, if the duration of R wave is less than 0.8 second, it is right ventricular hypertrophy. If duration is 0.08 to 0.09 second, it is incomplete right bundle branch block. If duration is more than 0.09 second, then it is purely right bundle branch block. So whenever there is increased height, that means that the strain is happening. That means the muscle is working more to get the blood pumped out from the atrium. That leads to associated finding of right ventricular hypertrophy possibility underlying. When you see such pattern in this ECG, if you see, because QRS is crammed up, you can see that in 6-year-old we have T wave inversion, V wave in V6 we have T wave in positive deflection. Rest, again, when we go back on limb leads, we see that P wave is positive in lead 1. In AVF, P wave is positive. In lead 2, P wave morphology and sinus rhythm is seen. In lead 3, Q wave is normally seen. In AVL, there is no Q wave. There is positive R, then S. In V1, we have RS R dash pattern, and height of R dash RS R dash pattern is suggestive of right associated right ventricular hypertrophy with right bundle branch block. Again, in this, we can see that in V1 specifically, we have RS R dash pattern with again height of RS. Again, height of RS will be more. So when we have RS R dash pattern, we need to understand that RS R dash pattern associated with height of RS R dash pattern tells us about right ventricular hypertrophy. With RS R dash pattern with height less than 10 mm, we need to further dig into the cause for disturbance in the conduction of electrical current through the cardiac musculature. Most important lead for telling about RS R dash, V1, because age wise we can say that the right bundle branch block will have a M pattern. RS R dash in morphology of M Guys, we will be closing this session at the moment because I got a message from the admin that our time limit for 1 hour will be done. So now I'm opening the session for the questions, and also if you have some doubts, you can unmute, or you can type. You can type the questions, as well as if you have any problems, then you can type it here on the chat box as well. Do we have any questions from anyone? Sir, can you send recorded session on the group? Sure, I will. I generally do not recommend recorded sessions for these talks because I believe ECG is something which each one of you should be aware of, but there were certain issues today, and there is